So Joseph is my name, Joseph Kazwe. I'm a cardiology ST6 at Northern General, that is South Yorkshire. And today I'm going to be speaking to you about common rhythm devices in cardiology. That's we're going to be for the next 30 minutes. For the next 30 minutes, we're going to be starting off with exploring of diagnostic, exploring the diagnostic utility of these devices. We'll move on to some devices that we use in bradycardia you're likely to encounter. Some of the devices, cardiac devices that you're likely to encounter in tachycardia, and those that you're likely to encounter in heart failure, or you've already even encountered. We're going to be using mainly a case-based sort of setup, because I'm sure most of you have already encountered most of these. So the first one, I'm hoping everybody can see case one. We have a 28-year-old female with palpitations. You're the F2 on call. She reports sudden onset and offset lasting for about 20 minutes. Palpitations, they have sudden onset and offset lasting about 10 minutes on average. You do your physical examination, which is unremarkable. You do the blood tests, they're unremarkable. You do an ECG, which is normal sinus rhythm. How would you likely proceed? I'm going to be looking at the, so if we look at the, if we go to the chat section, how are you likely to manage this patient? Are we admitting to a monitored bed? Are you going to be starting them on aspirin, discharge, and Holter monitor, or inpatient coronary angiogram? So I'm just going to the chat. It says 3 minutes. So I'm seeing lots of C's. Okay, very well. Well, it looks like we are already preaching to the converted. Right. So I hope that is coming as, it's coming in the presentation, in the slide format, your side. Right. So yes, I would agree with, I think everybody managed to get that, not just pain C. We're talking about Holter monitors. So the things, most of you will have seen this, 24-hour Holter monitor, 48, 36, 72 a week. And what they really are, they are some of the commonest devices we use in cardiology, event monitors, to try and ascertain rhythm symptom correlation. So I'm just going to go over that again. So it could be anything, it could be nothing. But what we want to know, because the events are on and off, we want to know what is happening during those 10 minutes. And we want to be able to catch it. So she's looking quite well. She doesn't need an inpatient coronary angiogram, but we want to monitor her for a period of time. We give her a diary, and then, these are the common monitors they're going to be using. They'll have them for 24 hours. And when they feel they have the symptoms, they can take down the note, and then we can see what their heart was doing at that point in time when they had the symptoms. So we can really do rhythm symptom correlation. And we could decide to do 24 hours. We could decide to do 48 hours. We could do 72 hours. So in this one, if we go back, lasting 10 minutes on average. So how would we choose, just to check? Would you, again in the chat, would we be going for 24 hours? It's a young girl. I think it was 28 years of age. Right. Would we be going for 24 hours, 36 hours, 72 hours, or a week? What are people likely to do using the chat? Not sure. The other option is not sure. Any responses? Brilliant, brilliant. Depending on the frequency of symptoms. Yeah, so that takes us, yes, so depending on the frequency of symptoms, if, we're getting them daily, probably 24 hours, if we are getting them every once in a week, so if you monitor for one day and you don't see anything, it depends on the frequency of the symptoms. Right. On the next slide, we're looking at another sort of event monitor that we commonly use, and I don't know if people have come across this. So there is another device called cardiac device we could use if we didn't use a Holter monitor, if we didn't use the one here. So there is another device that is on the market, but it is also available in some hospitals. It's worth knowing in some hospitals. I worked in Pinderfields. I actually don't know, Lydia might know whether it was there. Yeah, but there are some cardiac devices. They have been approved by NICE, and these are usually also for supraventricular tachycardias. You can see the two bits. I think it's on the next slide there. You can purchase them, put them on your phone, you synchronize them with your phone, and when you feel you're getting those palpitations, you can put your two fingers and it records an ECG that you can be able to transmit to your GP, to your cardiologist, to whoever healthcare provider it is. So the beauty with them is that, most people, as you know, nowadays, the phone is everywhere we go. So you might have palpitations that come in a very unpredictable fashion. They might be coming maybe once every so often. This is a simple device that one can move with their phone, and they are used in some of the trusts. Other trusts might not have them, but event monitors, they do essentially the same thing. When you get the palpitations, you put your fingers and we can see what your heart is doing at that moment. It's very important for us to remember that word again I've used for rhythm symptom correlation, because sometimes actually we see and they feel the palpitations, but you see a proportion. There is nothing happening. It's normal sinus rhythm and good heart rate. And all people need to do is to be reassured. And once you give them the evidence, that is enough to manage them. And for other arrhythmias like SVTs, we're able to make diagnoses based on those devices. So those are some of the common ones that we use, the Holter monitors. The cardiac device is another one. I'll just go slightly to the next case. 85-year-old attended hospital with an episode of transient loss of consciousness. It's blacked out. Reports that first time he blacked out was about 8 months before. You do your physical examination. If they're 85, they might be having aortic stenosis, so they have no ejection systolic murmur. They have no postural drop. Their physical examination is unremarkable. You do your blood tests. They are stable. The A&E team are saying you're on call for medicine, and they're saying, no, you need to look at this patient. You do the ECG. It's normal sinus rhythm with a first-degree heart block. So the PR interval is 220 milliseconds. What are the management options are we going to go for? Are we going to discharge this chap? We've looked at a cardiac device. Remember, cardiac device. This one. I think the other name is Alive Core. Are we going to organize, now that we know a cardiac device, you're in a trust that it has one? Are we going to get a 24-hour halt and discharge? Or ILR? Using the chat box, let's have a look at the options people would be interested in. A, reassure and discharge. I think we have about 50 people. I'm seeing only one response. Oh, B, 2. D. Okay, we'll give it a few more seconds to see where it swings. So 2D is 1A. So I'm very C. Okay, C, D. Okay, very good. So I'm very, that gives us an opportunity to explore the options. So nobody has chosen B, cardiac device. So cardiac device, if you remember, you need to put your fingers on it. If you black out, you're not going to be able to put your fingers on it because you're really unconscious. So clearly we're going to be eliminating that. Then I think there was a reassure and discharge. He's blacked out before. Probably we need to look in further. 24-hour halter. Somebody said, remember the first time he's blacked out is 8 months. It might take another maybe couple of months, maybe another 8 months, another year without blacking out. So probably 24 hours if you do it. I think it's a good start, by the way. Yes, you could do it. And if you catch something, well and good. But if you don't catch anything in 24 hours, in case it doesn't black out, probably we need to be looking at other options. So I think D, which most people have gone for, is the implantable loop recorder. So I think probably C and D are right. But if you don't catch anything on C, you probably go for D. ILR, implantable loop recorder. So this is, if we need to monitor for longer durations, for months, this is the, you'll be hearing it. He has a loop recorder. That is what it looks like. It has a battery, it has its programmer there, and it's able to keep an eye on the, again, same thing, symptom rhythm correlation, but they can last in for longer periods, for about 2 to 3 years. So very useful for especially patients who, they've blacked out, they cannot put their fingers on the event monitor. So this one will monitor, when they blacked out, you can see what they were doing. And, the ones on the market, the batteries last generally about 2 to 3 years. Quite useful. Sometimes, we put them in and we catch lots of things. So you're able to tell if they go intermittently into, ventricular arrhythmia, complete heart block, ventricular standstill, whatever it is. So these are preferred for a longer period of time. And I think, it might be that, yes, you might do a C 24-hour halter, you find nothing, and ILR is perfectly a reasonable thing. We've already touched on this. The frequency of the symptoms guides you on what you're going to do. My own strategy, so you might find that me and Lydia, if we look at that patient, Lydia might start with a 24-hour halter, and if she catches something, you probably don't need an ILR. If the patient has been in hospital and you've monitored for 24 hours, you probably don't need another 24 hours. You just move straight to an ILR. I think the take-home message here is having an understanding of what we're going to choose and why we are choosing it. So daily symptoms, keep them in hospital. You can do a 24-hour halter, 2 to 3 days, monitor for 48, 72 hours. And the week, use that as a guide. And if it's, less than a month, you're having symptoms once in 6 months, 8 months, there is a very good resource, implantable loop recorder. Do not use cardiac devices for people who are blacking out for simple reasons. They won't be able to correlate the symptoms with a loop. You need to be able to use it. So it's usually for supraventricular tachycardias. Right. So move on to the next step. So you've the last patient, we put in an ILR, and after 6 months, it's shown this recording. So in this recording, we can see there is a lot of, there is good contractions, but then we see that the P waves are continuing, but there's no ventricular activity. And that's why this patient is blacking out. It moves us to the next chapter about the other devices you're likely to encounter from a cardiology perspective. That is pacemakers. When you hear the word pacemakers, we would want you to think about bradycardia. Bradycardia is a term used for slow or absent, asystole if there is no, but usually slow heart rates that cannot give you a good cardiac output. So pacemakers, I'm sure you will see. If you haven't seen, you won't finish your rotation without seeing any patients with a pacemaker. And what a pacemaker really is a cardiac device with a usually implanted on the left side. We put them in the prepectoral area. We put the generator there, and then we put a lead or a wire down using, the axillary vein. We use one of the big veins. We go into the right side of the heart. And, sometimes we put in one chamber, sometimes we put in 2 chambers. When it is 1 chamber, we call it a single chamber pacemaker. If it is 2 chambers, a dual chamber or 2 chamber. We put in one lead in the top in the RA or one in the in the RV. Pacemakers, the components they include, we call many people call it the battery, but we call it actually a generator. It's more than a battery. You'll see box changes. So the generator, this is the kind, and it has where you put the two leads or two wires. Well, two wires, but we call them leads. And looking closely at those wires, that is the wire we put this side on the generator, and this side is anchored in the heart. Generally speaking, it's important for us to know there are mainly two kinds of leads that we use. There are those that are active fixation and those that are passive fixation. So when we put it in the heart, active fixation, we screw them. That is the screw drive at the end. There are mechanisms for it. So they anchor in there. And there are some that are passive. They just have tines that log into the myocardium or structures there. We mainly use active fixation leads. You can put them in several places. They stay more stable and they're easier to remove for extraction purposes. If they get infected, just like Lydia was telling us. So that is what generally a pacemaker is. So these are the leads. Going back to that picture, the generator, put it there, bury it, put one or two leads down, and every time the patient is getting bradycardic going to 20, then the pacemaker kicks off. The next slide, it shows us there are some people where that vein is blocked, or some people where these vessels are blocked. Sometimes we can't put them on the right side as well. So if people have infections here, we can put it on this side. But sometimes all these veins are blocked and we can't, like renal dialysis patients, they've been putting in lines and they are clogged. You can't put pacemakers. So there are other options. They are what we call leadless pacemakers. Those are new on the market. There are other reasons we can put them if people people have high infection risks. We can put them, they are put in the right ventricle. That is to show you one, and this is an X-ray with somebody having a leadless pacemaker. And that is mainly for bradycardias. Now, so take-home message, the heart is going very slow. Remember if there's nothing reversible, then pacemakers. So the next case, 45-year-old has had an out-of-hospital cardiac arrest, VT requiring 3 shocks. They come in, they do a left heart catheter. It's normal. The bloods are normal. You do the ECG and you do a cardiac MRI. They are all normal. How are we going to manage this patient? So you've got documented VF, VT, but everything, there is nothing reversible. What options are we going to look at? Are we going to implant in a loop recorder? Are we going to give them a pacemaker? Are we going to give them an ICD and Holter or Holter? Right. So it looks like everybody has caught up on that. ILR, we don't need it because we already know the diagnosis. Pacemaker, not because we know the issue is not bradycardia. We're not haltering because we already have documented VT, VF. So we're going to put in an ICD. So an ICD, what it is another device similar to, it belongs to similar, you can say similar to the family of pacemakers, but this time it is for fast heart rhythms. So we have an ECG here of a very ugly, fast-going rhythm that is causing cardiac compromise. So we do similar to a pacemaker, another lead down into the heart. But this time, this lead, when the heart goes into a very fast rhythm, it shocks the heart out of that rhythm. So those are called ICDs. So this is a transvenous ICD. Sometimes they can be subcutaneous, not transvenous. So we can put in, especially for young people. So one of the disadvantages of transvenous pacemakers, transvenous ICDs is some, can get infections. And remember what Lydia, we've just had endocarditis. When the devices are infected, they need to come out because otherwise they're going to give us endocarditis. So sometimes we have to put, young people who have channelopathies, they are going into cardiac arrests, ventricular arrhythmias. We can put in ICDs that are outside, like this one is made by Boston. It's a subcort ICD. ICDs are for fast rhythms. This is an X-ray of the ICD when it has already been put in. So you can see the battery here. Has anybody met any of these patients? through the with a subcot ICD? I'll take that as a no. Right. So this is how it looks like. This is a PA picture. This is the lateral picture. This is the shock coil, and this is the generator. So again, I hope this is projecting well on your screen. This is, to just show you that these devices look similar. If you're in A&E, you can see them. So this is a single chamber pacemaker. This is a single chamber ICD. And what I wanted to show you, the generators are going to be the same, similar, although, generators or ICDs are a little bit thicker. You need more battery. But if you can see here, the coil, it's thicker. I'm hoping that can project well. This is thin all throughout. But ICD, this is a dual coil ICD. So you can see it's thicker there and thicker there. So it can deliver shocks. So just by looking at the X-ray of somebody, you can tell whether they've got a pacemaker or an ICD. Most ones we use now are single coil, not dual coil. Technology has improved a lot. Now, earlier on, we talked about pacing. So far we've talked about slow heart rates. We need to pace them. Fast heart rates, we need to shock them. We can do ICDs. We can do transvenous. We can do subcot ICDs. As you know, most things in medicine, it is never 100%. There is also a principle where we can pace fast heart rate, and that can be applied in fast heart rhythms. Well, can be a little bit confusing, but just to, there's what we call anti-tachycardia, ATP, anti-tachycardia pacing. So if sometimes, if the heart goes very fast, VT monomorphic, it's going about 170, we can overdrive pace it. So you pace, so this is an example, the VT, somebody's in VT, then this is pacing, they've had 8 beats at a faster rate. So they are going at, say, 160 VT, overdrive them at 180, then you stop, and they come back to sinus rhythm. So it's something we call painless therapies in management of fast rhythms. So although pacing, generally we pace slow hearts, yes, there is a role of also pacing in fast heart rates through painless therapies, what we call ATP. And the whole point is, if they go faster than it, take over the rhythm, then slow down, and it stops. It's just like when police is chasing you. It overtakes you, goes in front of you, and it decelerates, and you've got to decelerate. So on that rhythm, on that principle, we have also a bit of ATP we can use in devices. Now, the last case, so you can see in the last 5 minutes, we'll look at the other section of devices that we use. Using this example, a 62-year-old patient who is heart failure with reduced ejection fraction, has been on all the pillars that Dr. Shark has told us in the second lecture. MYTT, they've got ECG in sinus rhythm with a left bundle. Now, if you remember, she touched on devices, when you've given all the therapies. So there is a role of devices. So next step in management, are we giving dual chamber, ICD, CRT-P, CRT-D, dual chamber, PM? Can I see some options as we wind up? So heart failure, you've given all your 4 pillars. What would you want to do? Devices. So I can see CC, right? I think, yes, I'll go with you. So generally speaking, 62 years of age. I've not given you much history, but yeah, CRT-D appears the most appeasing thing. It can be a P as well, depending on the comorbidities, but most likely CRT-D. I'm in agreement with you. Dual chamber pacemaker, we know that is not a problem. In fact, it will make probably things worse. Oh, dual chamber ICD and dual chamber pacemaker, they are not the options we're going to be looking at. So what is, when you hear about CRTs, what does that mean? It is cardiac resynchronization therapy systems, and we can do CRT-P or CRT-D. So the primary objective is to bring back synchrony in the left ventricle when it is pumping. You've given all the medications, and you want, but the ejection fraction is not improving. People are still they still have symptoms. So CRT has 3 leads. Remember, we talked about pacemakers, dual. So we have in the right atrium, in the right ventricle, and then this one, the third one goes, we call it the LV lead, but it actually goes outside through the coronary sinus and wraps itself on the outside. So the first 2 are endocardial, but the outside, the LV lead for CRT is epicardial. It goes on the outside. We usually prefer the postlateral vein. And the whole point really is premised on conduction. When people have left bundle, when we look at the conduction, we know it passes through the septum. And if you have normal conduction, it should reach the lateral wall of the LV quite fast, as you can see in the speeds here, and give you a narrow QRS. But if there is problems with the conduction, it will come very fast on the septal area, but it takes forever to reach the lateral aspects. And that causes the desynchrony or the widened QRS that we see as the left bundle. So CRT is to try and pace that left side faster and minimize the desynchrony and improve on the symptoms and ejection fraction. So this is a chest X-ray of a CRT3 lead. So you can see one in the RA, one in the ventricle, and this is on the outside. This is again a CRT3 leads, one in the RA, one in the RV, and one on the outside. Now, if you look again closely, you will be able to see that this is thicker here, and this one is thin. So this is consistent with the CRT-P, but this is consistent with the CRT-D. D because of the defibrillation here. It is thicker to be able to provide energy. So it should be able to shock people. So there is good evidence that CRTs for the right people, they improve heart failure symptoms. So on just the X-ray, you would be able, I'm hoping going forward, you should be able to look at the system and you can tell what exactly, what kind of device the patient is having. So putting everything together, we've had a quick overview on the common devices that you're going to meet in cardiology we use. When it comes to monitoring ones, the nature and frequency of symptoms guide the choice. Cardia, not for people who are blacking out. No need to monitor using an INR for somebody who is having daily symptoms. The devices can be useful for both slow and fast rhythms. And somewhere there is an interaction of where we can use some concepts. We can borrow concepts for an intersection. And lastly, we can still use these devices to help with heart failure when the medications that we've studied through their mechanisms have done their work and we need more improvement. We can use these devices to improve patient symptoms and actually mortality. And that brings us to the end of the lecture.